What do we got here?
Okay.
Sir, bad boys have to sit up front.
Okay.
Oh.
I don't want to be. No,
Are you a bad boy?
You got it gone right. You just asked my wife, you know?
It's a lot more fun.
You want me to sit right in the middle where your bag is?
Okay. You sit wherever you wish.
Is that a golf club?
No, this is a squid, just like in school, remember when you misbehaved and they,
3 times on the hand?
yeah. Or somewhere else.
Okay.
Ask everyone again.
Working on trying to lower the temp a little bit. Several people have said they're too cold, so we're trying.
Raise it,
Raise it,
lower it.
lower the temp. There you go. I was trying to have it too much.
Yes, ma'am.
Yeah.
Well, they can sit next to me. I'm having my class.
Seconds, look at you. Yeah.
I think need to room my own personal summer.
Years ago, one day in the office.
Yeah.
You started describing the symptoms. I said, you're having my pleasure. She said, no, I'm having powers.
I call it my own personal summer.
Yeah.
Get everywhere with me.
It was much more neighborly than powers.
Yeah.
Oh, brown out.
My wife had this directed. One evening, it was snowing outside, just barely low. She went out there and hiking about 2 o'clock. Steps, stood on the front steps and said, this is fun. I don't you going, flat out crazy.
I thought this well into the winter, not just without waders, and we were like, how are you?
Yeah,
How
yeah.
are you doing that? You ever had a hot blood and waders? I just think I'm a badass though.
Just a couple more minutes and we'll get started. So how long have you been married for, sir?
2 weeks ago. 22 years.
Well, good for you. Congratulations.
Yeah, thank you.
You must mind pretty good.
I did. I've only lost one argument.
Which one was that?
The first one and the most recent one.
I'll have to remember that one for a minute.
The good life. It's a good life.
Are you looking for tools or navigation? Tools and tips, or this is navigating end of life? Okay, you're welcome. I'm supposed to be your partner.
Okay, that'd be great.
Hello, everyone. Thank you for being here. I would like to introduce Dr. Ralph
Caldroni.
Caldroni.
Sounds like macaroni.
Dr. Caldroni attended Washington and Lee University, class of 1972, MCB 1976, trained in internal medicine at the Medical University of South Carolina, fellowship in critical care medicine at the University of Florida. Dr. Caldroni spent 7 years on the teaching medical staff at University of Kentucky Medical Center, and then 25 years in private practice in Lexington, Kentucky. In addition to private practice, Caldroni spent 8 years in the Army Reserves, volunteered with deployments to Landstuhl, Germany, Camp Bucca, Iraq, and Kandahar Airfield, Afghanistan. He has served as medical director at Rockbridge Area Hospice, on the RAH Board of Directors, and on the VPAS Board of Directors. We welcome you and thank you very much.
They buffed up that bio pretty nicely. I want you to know that my wife told me I'm not on her top 30 speakers.
Okay.
I want to talk about something relevant to end of life decisions. And when I was first asked to talk about navigating the end of life, I thought it was just too broad a subject. And I wanted to try and narrow it down a little bit. So I focused in particular upon the question is hospice a potential intervention for you or one of your loved ones? And I'll show you some statistics here in just a little bit to support the idea that many, many people do indeed entertain the possibility of hospice involvement as they approach the end of life. But I wanted to describe from the inside a little bit what actually happens. What is the hospice mechanism itself? So let's go upon a couple premises. We're all going to die, right? All right. Most of us are going to die a natural death. All right. Now, I may go home tonight and catch a cast iron skillet upside the head. That would be an unnatural death. All right. But most of us are going to die a natural death. And most of us are going to die a natural death from disease or diseases. And most of us who die a natural death from disease or diseases will have a slow downhill course where we do have some time to prepare. We do have some time to say our goodbyes. We do have some time to make choices about how we want the end of our life to transpire. How are we going to die and where are we going to die? Now, there are some people certainly who live to be 87, keel over out on the street, and they're dead within a couple of minutes. But statistics unfortunately tell us that most of us are going to have that slow downhill course. Now, I think the key thing, and I think what hospice has to offer perhaps more than other alternatives, is the emphasis upon quality versus quantity of life. And for many diseases, and we'll use dementia as an example, we may have a considerable period of time where we are incapacitated mentally and physically. We're still alive, but are we really alive as far as quality of life? Now, quality of life is the key term because everybody has a different definition. All right. Some people cling tenaciously to every breath of life. Some people have their own internal convictions. They may have spiritual convictions. So only you can define it for you or for your loved ones. But the key thing here is that at least entertaining hospice or some of the other alternatives gives us the choice of making decisions before the crisis occurs. It's a system of care and aimed at the end of life. Again, emphasis upon quality, not quantity, all right? Typically, care is provided in the home environment. Now, if you query most adults in this country, they're going to say if you had a preferred place to spend your final days, they're going to say it's not the hospital, it's not the nursing home, but it's at home. The sad reality still is that so many deaths that do occur don't occur in the home environment. Care is provided, all right, to everyone and anyone. Now, there are for-profit hospices. Rockbridge Area Hospice, of which I was involved, is a not-for-profit, but for the most part, most hospices are going to accept you as a patient assuming there are appropriate criteria regardless of circumstance. For most, it is covered under Medicare insurance, right? And parallel insurance. In fact, this is a situation in which other insurance plans, Blue Cross Blue Shield, Humana, et cetera, follow the Medicare model. Now, these statistics were drawn from the pre-COVID timeframe, and that's important because the whole dynamics changed during COVID. So many people, especially elderly, were getting ill and dying rather precipitously that the question of hospice involvement could not necessarily be entertained. But at least back in 2019, you could see that the majority of people who died who had Medicare as their primary insurance at least opted to have potential involvement with hospice. So, you know, there's knowledge enough out there that hospice is an option that many people do indeed entertain it. And that's particularly true for the oldest of the old, okay? You know, people 85 and above, and they see so many of their peer groups die, you know, they get up every morning and read the obituary column before they read anything else. I do, okay, all right. But they're in tune to the idea that hospice is there as an option. And as you look at the older age groups, more and more of them entertain and involve themselves in hospice. Now, a brief history of hospice is appropriate. We talked about cave people just a while ago, all right? I can envision a scenario in which there is an elder couple in the tribe, and he's dying of some type of unforeseen illness. And she has made up the bed of furs as best she could. She's warmed up the fire as best she could. She's holding him in her lap. She's soothing him. She's caressing him. She's speaking endearments, and she's by his side ceaselessly until he finally dies. And I think for most humans, compassion is part of our fabric. Certainly there are aberrations, but compassion has been around for a very, very long time. Hospice as a specific system really did not get formalized until the 1960s in Great Britain and eventually penetrated into this country and eventually became a covered Medicare benefit back in 1982. The question was, why did Medicare decide to give coverage to this concept if it was only a relatively new invention? Was it compassion on the part of the government? It was more, okay. I think there was some element of compassion, all right, but it was mainly the financial end of things because they had by that time been able to demonstrate that people who died under hospice care, the expenditures at the end of life were less than they were under the traditional system of care where people bounced in and out of the hospital, in and out of the nursing home, all sorts of interventions. You know, that's why it became a covered benefit. Now, the process, and I want to talk a little bit about this so you understand what happens. The first and foremost thing is a referral to a hospice organization, right? So who can refer? Family,
Trustee.
trustee, right?
Doctor.
Doctor, provider. So it doesn't have to be a medical professional, okay? It can be someone within the family unit who can make the referral. Now, one would certainly hope that's being done with the patient's concurrence, right? But recognize that some of these individuals who are referred to hospice organizations may no longer be fully intact cognitively. They may have a preceding dementing illness, right? They may have an illness which has rendered them incapable of making informed decisions anymore. But the vast majority of the time, all right, this is done with some concurrence on the part of the patient and or the prior stated wishes of the patient. Many of us have advanced care directives, or at least verbally we have discussed with our families and said, this is what I would want done if something happens, this is what I would not want done. So there is a referral process, and typically for most hospice organizations, once the referral has been made, then there's a fairly rapid turnaround time in terms of a face-to-face at the bedside assessment. Now, that changed a lot during COVID, and more of this was being done in a telemed kind of context, but my strong preference is I really think there should be a physical presence. You get a sense of what's in the environment, you get a sense of the family unit, you get a lot of things that you can glean from doing it face to face. So if I were someone who was having a family member involved with a hospice organization, I would certainly favor that be a bedside face-to-face assessment. Typically, once that assessment has been done, all right, and they've gathered all the background information, it's not just medical information, which disease or diseases, but a psychosocial assessment, a financial assessment, a planning assessment. Is this family planned for a potential funeral, and many, many other items? All right. Once that information goes back to the hospice office, then a decision is made, is this an appropriate patient to be admitted to hospice? And I'll talk about this in just a little bit, all right? Then there's a period of ongoing care. Now, that could be literally minutes. You know, sometimes we'll have somebody who's referred from the hospital ICU. They've decided they're going to take them off the ventilator, all right? And they know they're probably going to die within minutes to hours. But more typically, there's an interlude of days, if not weeks, and sometimes months, and sometimes years in which care is continued on. But I think a key thing for hospice organizations, and one of the reasons why, again, I favor it, the typical model, if you die during COVID in a hospital, okay, you're not involved with hospice, is you're pronounced and the family's out the door, and that's the last contact you're going to have with the healthcare system. Whereas hospice makes a specific emphasis. In fact, they're mandated by Medicare to do post-death follow-up with the family. And most hospices have specific bereavement groups, all right? Because nobody can really understand what it's like to grieve when you've lost a loved one unless you have walked that particular mile in your shoes, all right? So I think they do a very good job of following through after the death has occurred. Yes, ma'am.
Do you know if hospice facilities work with end-of-life doulas to provide that post-mortem care of the family?
Yeah, they try to. They try to. All right. Yeah, they try to. Now, I'm going to use my wife and I as an example about this quality issue. All right. I'm 71, soon to be 72. Don't tell anybody, but my wife's a little old. I am very active physically, right? I think I'm still intact here, although she has her doubts at times, all right? I enjoy being active. I enjoy being outside. I enjoy interacting with other people. If I had a disabling stroke and I became bedridden, right, and I could communicate minimally, to me, that would be a fate worse than death. I fear disability much more than I fear death at this point in time. So if that occurred, in all likelihood, I would tell my family, stop the interventions, get hospice involved, let me die as peacefully and gracefully as possible. My wife, she's more sedentary, okay? She's perfectly happy to do her crossword puzzles and Sudoku and chit chat on the phone and watch silly British murder mysteries and those types of things. So were she to become incapacitated, she could still find a significant amount of joy in life, right, from doing those types of things. And I suspect she would opt to have ongoing care for a longer period of time, recognizing that probably sooner or later she would have to transition into hospice. So again, only the individual can decide what defines a minimum level of quality of existence. Now, going back to this referral question, this is very important because sometimes people, say, well, yeah, we should talk about hospice. Then once the reality of what hospice means is presented to the patient and the family, they say, I'm not sure. You can go through this referral process. You can go through the initial assessment. You can actually be admitted, and then you can say, this isn't right for me. You're not obligated, once you're admitted, to stick with the program for the entire length of time. Though most people, once they've been admitted to hospice, stick with it. So it's not an all or none phenomenon. Now, what do we have to do as a hospice organization to say this patient is appropriate for admission? First and foremost, we have to say there's a life expectancy of 6 months or less. Now, there are certain tools we can use, mainly nursing tools, all right, that we can look at that are reasonable predictors to say that life expectancy is 6 months or less if the natural progression of the disease or disease evolves. But I have to admit, and I've talked to innumerable patients and families and say, when I look into that crystal ball, there's a heck of a lot of snow. All right. Nobody can really make a finite prediction. Probably the big guy above has a better idea, but certainly we can get a guess. We can make a reasonable guess. And they don't hold our feet to the fire, they being Medicare or the insurance companies, and say, are you absolutely sure? All right. You know, if I can say, yeah, these are the criteria, this is what I think is going to occur, then typically they are going to say, yes, this is an appropriate admission. And in fact, the majority of people who come in do die within that 6 month period of time, but some live considerably longer. I had patients go 2 and 3 years after their admissions. Right? And all I had to do was, after a certain period of time, generally every 90 days, all right, I had to say there's a downhill course. Now that downhill course could be ever so gradual, okay? But if I could say it's still going downhill, then they could continue to qualify for ongoing benefits, all right? Now, this is the key thing in terms of acceptance. If you are accepted to hospice, if you are admitted, you have to relinquish some control over interventions, all right? We would not expect that you would continue to receive chemotherapy, radiation therapy, dialysis, end up on a ventilator, all those types of things. And that's for a couple of reasons. One is we think, all right, when I say we, that's the collective we, hospice organizations feel that these types of interventions prolong life with lessening quality versus quantity. And the second is just the strict financial arrangement. You know, we had to cover the cost of these types of interventions. It could be very, very expensive. So if somebody is ambivalent, if a patient and the family is ambivalent about having these types of things, quote, withheld, end quote, right, then maybe hospice is not right for them, right? And the second major expectation is that you're going to avoid, like the plague, going into the hospital, right? Because hospitals are terribly, terribly expensive environments. Plus, we have to now factor in the risk of contagion, disease, you know. Are you going to be at risk for COVID or other types of illnesses, right? And a part of this recognizes the financial logistics of hospice organizations is where they are paid on a per day basis. You get a set amount of money per day for all the care that occurs, right? So they don't pay if you undergo chemotherapy. They don't pay if you undergo dialysis like you would with your traditional insurance. So again, it makes it difficult for any hospice organization to survive if we have to cover big ticket items. Now, what kinds of diseases might prompt a referral to hospice? It's really the whole gamut. The original focus of many, many hospice organizations was cancer, because typically with many types of cancer, there was a bad period of time, right, in terms of time of diagnosis to the time of death. But it certainly broadened over time to many, many neurologic diseases, dementias in particular, Parkinson's in particular. You know, I was talking to somebody just the other day, said, you know, why do people with Parkinson's now, so many of them, as they get older, develop cognitive problems, develop behavioral problems? And the reason is that they used to die from the muscle effects long, long ago. And now we have medications that can counter that to some extent. Life expectancy for people with Parkinson's has grown greater, but now we're seeing unfortunately, that ugly intervention where the degenerative portion of behavior and thought becomes a big part of it. Degenerative diseases of the heart and the lungs are important. Stroke, and I think we're seeing more and more, and sometimes we would have somebody admitted simply because they're 92 years old and they're frail. And it wasn't a specific diagnosis above and beyond frailty, but just that it's time. They're reaching the end of their lifespan. But, you know, this list could go from really from A to Z. All right. So it just all depends upon the disease and diseases and its effect upon your ability to do things for yourself. Now, I talked about the length of stay, that ongoing care period. Now, again, these are 2019 statistics, right? And the average length of stay is a little over 2 weeks, okay, which I don't think is a preferable model, all right? And in fact, a number of patients, up to 10%, are that kind of person who crashes in the ICU, they're taken off the ventilator, they die within hours, all right? And certainly hospices will provide care for this type of individual, but it doesn't do the full intent because it doesn't allow time for the family to prepare. That's the biggest part of that, right? And it also doesn't provide time, many times, right, to really control the most distressing symptoms. Is it pain? Is it shortness of breath? Is it restlessness? Is it agitation? Whatever. If I only have a relatively limited period of time as a physician to help control those symptoms, I may not be able to control them to the optimum and provide for what I think should be a good death. All right. And again, it's just limited time for the family to really prepare themselves psychologically and to say their goodbyes. So part of the message here is if you're thinking about the possibility of hospice being right for you or for a loved one, I think the earlier you make the referral, the earlier you entertain the question, the better. Now, the admission is typically the first person to make that face-to-face visit, if at all possible, is a hospice nurse. And these are the ones that really run the show. For those of you who had involvement with hospice, you probably recognize that these truly are angels of mercy, all right? They're the ones that do the footwork. They're the ones that make the emotional investment in the patients. Imagine grieving for a parent, all right? But these folks go through grieving for patient after patient after patient. So it's tough. It takes a very special individual. Again, they typically get the information back to the medical director, right, of the organization, and then the decision is made fairly rapidly to admit the patient, or at least technically is it appropriate to admit the patient, right? And again, is this someone that's appropriate for ongoing hospice care? I think a lot of that's dependent upon the acceptance on the part of the patient and their family that they're willing to travel down this path. We do try and keep the referral sources involved, in particular if it's a medical professional, all right? We're going to get information back. Your patient's been admitted. These are the diagnoses. This is what we plan to do. This is what we think the life expectancy. In fact, many patients, especially in rural areas, right, elect to have their primary care doctor continue to be involved in their care while they're under hospice. And that's perfectly appropriate. Some say, no, I want to turn that care over to the hospice physicians. But if at all possible, we want to have the doctor that you trust the most continue to be involved in the care. Typically, what will happen fairly quickly, in fact, many times during that initial assessment, once it's been deemed appropriate to admit the patient, is a comfort kit of medications is given to the family, all right? And I'll explain that in a little more detail in just a second. We also do an assessment to see is there anything that needs to be done physically in the home environment that will make it more comfortable for that individual. Do they need a bed? They need a bedside commode, you know, you name it, right? So that's oftentimes, again, assessed and hopefully rendered fairly quickly, right? Something I got involved in a fair amount was looking at the list of medications, you know. if someone has had a history of multiple heart attacks, they now have developed heart failure, and they're on a cholesterol lowering medication, is that really necessary or anymore if they're being admitted to a hospice organization? So some of it was just the practical matter. Is this medication really necessity? But it also lessens the burden on the family. Okay, it's just less things that you have to try and manage. And I think it also is a financial benefit many times to the family. And there are actually studies that have shown, for example, that cholesterol lowering medication in the patient with a known history of heart artery blockages, if you stop it, once they're admitted to hospice, they're not going to live any longer or die any more quickly off the medication than on. So it's out there. Now, the team itself, all right, we have to be available 24/7, right? Now, there's phone contacts, but at least with Rockbridge Area Hospice, if somebody had a problem, it's 2 o'clock in the morning, I expected my nurses to show up and be there physically. None of this, I'll see you in 3 days, kind of stuff, right? So at least there should be the possibility of not only rapid contact, but rapid turnover. And if your hospice is not offering that or going to follow through with it, then I would look for a different organization, right? A big part of what we do, and you heard with our prior speaker about social work component, right? You know, dying is not just the physical aspect of dying, it's the emotional, the financial, the spiritual components of dying. And the social workers and the chaplains in particular help with that type of thing. Volunteers are important. You know, sometimes we just don't have somebody who can be there 24/7 with a family to support the dying effort. And that's oftentimes the case, you know, with an elderly couple. You know, wife may have cognitive problems. He's going downhill, the kids are scattered all over the world. We don't want that individual to die alone. And sometimes our volunteers will sit in with them, right? We also have a specific group of individuals who have a military background, who connect with the patients who are of a military background, right? And then we have therapists for, you know, on occasion, we'll find something in terms of physical therapy, occupational therapy that improves quality of life, and we will get them involved. Now, what are we trying to do in terms of improving quality of life? There's an old saying in hospice, I may not be able to add days to your life, but I may be able to add life to your days. And a lot of that revolves around controlled symptoms, nausea, shortness of breath, pain, agitation, you name it. And we do have things we can do with medications or other non-medication interventions that may help to control those symptoms. Most of that's done at the bedside, and most of that's done by the family. And the primary tool, okay, I have to help with many of the symptoms are opiates, so morphine, fentanyl, you know, all those drugs that have acquired such a bad name, but they are very, very effective. It's very important to state that rarely does a hospice patient become addicted to opiates, all right?
Right.
Addiction means the physical dependence upon medication, the craving for the medication, all right? Abnormal behavior related to medication. And why is it different with these patients? Well, we're given a dose that's intended to control a symptom, not to produce a psychological effect. We many times give these medications not only in smaller doses than an addict would take, but we give it on an as-demand basis. All right. So if you wake up at 2 o'clock in the morning with your cancer pain and you require a dose of medication, and you give the medicine and it settles down, and you're symptom-free 12 hours later, you may not repeat the medication. Now, there are certainly times when we use fixed schedules of medication, but again, opiates are very, very important. And a way to look at how these medications work, and some of you have probably had opiates at one time or another, it sort of disconnects the neck down from the head. You know, I give somebody enough morphine, you can put a stick into their arm, okay, and say, well, that looks ugly, but it doesn't hurt, all right? So it dissociates the physical manifestation in terms of the symptom from what you're feeling. That's it. Yes, sir.
Yes, I'm just curious, does the use of those drugs ever hasten the dying process?
Yeah, it's a good question, a good question. The answer is yes and no, and that's a very ambivalent part. And I think if we target the drugs and using the appropriate dose, we use it to take the edge off the symptoms. We use them intermittently. In fact, the literature would say, no, we're not speeding up death. But I will freely admit there are times, or especially when the end is near, and we have distressing symptoms with pain or whatever, that I may put somebody on a fixed schedule of medications. And if that cuts their life expectancy short by a day or two, as long as the family is willing, I am willing to accept that. Okay, but overall, probably not, in contrast, right? Again, we use other medications for symptom control, and maybe steroids and nausea medicines, you name it. So we're pretty well willing to use whatever is necessary, but emphasis is that opiates are the primary mainstay, and they can control or alleviate many of the stressing symptoms, right? Now, we typically, again, use some ongoing list of regular medications. There are some that are there for quality of life. You know, if you're on insulin and I stop your insulin and your blood sugar goes way up and you're thirsty all the time, and you're peeing all the time, that's not very comfortable, is it? All right. All right. So some medications we do maintain, and some medications we may even add in for symptom control. So it's sort of a dance that you have to keep up with. Now, this is a question I think that doesn't get asked enough or answered enough. And when I would go and make face-to-face visits at the bedside with patients and their families, you know, I'd ask a series of questions. But one of the questions I would ask would be, would you like me to explain what I think is going to happen? Would you like me to explain what I think is going to happen as you get towards the end? And more times than not, based upon their constellation of disease or diseases, the medications I was giving or not giving, the natural evolution of their disease is that they were going to go into a coma. Right? They would gradually become less and less awake. They would gradually become less and less alert. And typically within 2 days, 3 days of the death itself, they would completely go to sleep. And if I'm going to die, that's the way I want to die. All right. Maybe not the cast iron skeleton, all right, but go into a sleep from which I do not awaken. Does it apply to everybody? No, all right. But I would say the majority, yes, yes, sir.
I can see a potential conflict here where you are put in a position as a doctor or the provider saying, do you want an end of life, pull the tubes, etc. And the power of attorney said no.
Yes. Yeah.
So you are directed by the patient's wishes or the power of attorney?
I am directed by the patient's wishes.
What is their judge to be conducting?
Yeah, then we got a real bit. Okay.
Okay.
All right. So typically what I'm going to do is my fallback in that situation is enlist the family. Okay. Say, you know, what did dad or mom tell you? What did they really want done? Although I think fortunately for most of the time, because power of attorneys are self-selected, right?
Mhm.
You've got someone you trust, you know, that is going to fulfill your wishes. In fact, the opposite probably applies more than that, and that is you've got 3 or 4 kids, you know, one's out here at an extreme, and the other is say, let's do what mom and dad told us, but one wants everything done. Okay.
Mhm.
And many times when we are approaching that very end stage, and we also talk about the question of hastening death, all right, and then I may have to use multiple medications to help control symptoms, all right, and there that increases probably the time frame into which the coma occurs and may hasten death for lack of better terms. But again, as long as I have the concurrence of the family and I know the patient's prior stated wishes, I think to me, that's a more merciful way to die. All right? I think it's a more graceful way to die. So what is a good death? You know, everybody's got their own definition. Mine is, I want to be in my home. Okay, I want to leave that home toes first, toes up. Okay, I do not want to go to a hospital. Right? I want to be as free of pain as possible. All right, and if you give me a little more morphine to help control that pain, and it hastens my death by a period of time, days, typically, so be it. Okay. I want spiritual support for my family. I'm not a particularly spiritual person, but if they want it, sure, I want it to be. And I want all those arrangements to be done before I die, as far as funeral preparations. In fact, I sat down with my kids a couple of years ago and said, this is it, A, B, C, D, E, okay? So they don't have to deal with that emotional burden as they're trying to go through the grieving process. But again, everybody has their idea of what a good death is going to be. And I would encourage you to think about that. Write it down, discuss it with your family. It's painful, it's no fun, okay? But only you can define it. Well, I asked for hospice at the end, sure as heck will, if possible, okay? I know it will be important for my spouse. Yeah, we've been married a long time, it's be tougher. Okay? It'll be important for my kids, probably going to be more difficult for my kids than it's going to be for my spouse. All right? And I again want symptom control, all right? Especially if it's pain. All right, but again, opiates can help with lots of other symptoms, all right? And I want them to be helped with the grief process. And I think the grief process begins before the patient dies, not necessarily after the patient dies. At least in my experience, are those who go through anticipatory grief suffer less intensely after the death than those who have not had time to prepare. Now, do you have alternatives? Okay, right? Palliative care. Okay, I'll talk about that in a second. Now, still many people opt for regular care. Look at all the people during COVID who died in hospital. All right, now part of that was just the process, the disease itself, where they didn't have time to repair. All right, part of it was the rapidity with which the downhill course occurred. But still, there are many people, all right, at the end of life with cancer or whatever, who want to go back and forth to the hospital, want to go back and forth to the emergency room. So be it. There is a thing called palliative care, which has much the same concept as hospice, all right, but does not have a defined time limit to it. I don't have to say that life expectancy is 6 months or less, all right? And also with palliative care, if you think chemotherapy may not be curing the disease anymore, but may help to control symptoms, you can go on with it because it's a different billing model. All right, that is, it's billed on a fee for service, not on a capitated daily basis. All right, and another example would be, let's say we have a patient under hospice care, their kidneys continue to get worse. All right, they want to cling on to life. They want to have dialysis for a while, even though they know they're going to eventually die. They get discharged from hospice. They can be admitted to palliative care. They can try a couple of runs of dialysis to see how it goes and whether or not it adds to their quality of life. Right? And then if things evolve, they get worse in spite of it, or they decide, no, I don't want to continue to undergo dialysis, then they can be readmitted. It's not quite as easy as it sounds, but you know, this is an option for somebody who may not be psychologically ready to say the end is coming, okay, or the family is not quite ready to say the end is coming, or wants to exhaust all their options before they say it's time to begin to limit care.
Would you say that palliative care is what I call more of a transaction processing environment?
Yes, yes, sir. Absolutely, yeah. So
Could he,
you certainly, as a patient and family, have much more control over what you want done or not done versus the hospice involvement, because mainly because of the financial model, we just can't offer certain things. Plus, Medicare will dig us. If I had a patient who's admitted to hospice and then they undergo dialysis, they're gonna come down on us very hard as a quality of care.
well, and sometimes you have to sign something that says you're not looking for a cure, you're looking for
Yeah.
comfort.
Oh, no, I understand.
Yeah, but a good question, right? So I will be happy to entertain questions, and I'll finish with this harsh statement that, in my mind, having been a practicing physician for many, many years, and particularly being a hospice physician, right, that I didn't feel like death was always enough. I think there is a time in life when we again have had such an erosion in terms of our quality of life that we may be living, but are we really living? My father died in his early 90s, and about 6 months before he died, with a combination of things, he said to me one day, you know, I'm existing, I'm not living. That was pretty prophetic. Okay. And not too long after that, we got him admitted to hospice, and within 6 months, he was dead. But he was existing, but he wasn't really living in terms of what he defined as an adequate quality of life. Okay. So thank you for your attention. I'll be happy to answer questions. Yes, ma'am.
So we're walking through this dialysis situation right now.
Yeah.
My ex-husband, who I'm helping to care for,
Good for you.
has been on dialysis for a long time. He had a transplant and then they had to let his kidney go. We all can see that he doesn't have really any hope of quality life. He was in a nursing home for 9 weeks before he went into the hospital. He's been almost 3 weeks. He had an aspiration event. Me and my 3 girls all can see that he doesn't have hope of quality of life.
Right.
I asked for a DNR when he first went in and got it, but he was, I used the word ambiguous, ambivalent.
And then what?
He's not ready to say that. And I had asked for hospice within a couple days and the doctor recommended that. He said, no, he's not ready.
Yeah.
He doesn't want to say no to dialysis. And it was interesting, it kind of helped me to see that there's a different financial model because I feel like we need the help of hospice to guide us through these last days. But he can't be on dialysis because he's not ready to say no. He can't be on hospice because he's not ready to say no to dialysis. It sounds like it kind of all comes out of one pot at that point, and there's not money to really pay for dialysis.
Yeah.
So we did ask for palliative care. They came, and the only thing I guess that they really did was say that, okay, yeah, let's give him the water. Because he went through a really tough day where we thought he was gonna die.
Okay.
And, but they wouldn't give him any pain medicine because it might take away his drive to breathe. He's at the local hospital here right now. So it's been a tough navigation, and I think he's gonna fight to the bitter end.
Yeah.
I think that's what's gonna happen.
Well, first and foremost, bless you for having such a kind soul, and as do you, it's okay. Our palliative care, I think, is indeed the right option. If I was his doctor, I would sit down with him when he's lucid and say, how much time do you think you have left, right? You know, what do you fear the most as you approach the end?
Yeah.
You know, what do you think your death event might be like, all right? And how can we help you through this whole process? So again, what defines a minimal quality of life to you? But he sounds like one of those individuals where he is going to hold on to life tenaciously, and bless his soul for having that kind of mindset. But I think you're taking the right path. Yes, sir.
Yeah, I just have a comment that I make to families sometime when I get involved. I do mediations for elders. The family many times is experiencing a living death,
Yeah.
while the patient is experiencing the resistance to that. And the stress issues and the conflict issues begin to emerge. And in addition, then they go, oh, you know what, we really don't even have our affairs in order. And then you add that layer on top, and it can become a very unfortunate, unsavory environment for everybody.
Yeah, thank you. Appreciate it. Yes, ma'am.
So how do you have a good death if you have had dementia?
I think in my mind, this is my own personal, view, okay? If I develop significant enough dementia that I become bed, chair bound, okay? Then I'm already dead, all right? You know, the body may be there, but I'm not certain the spirit is any longer. So again, depending upon the mindset of the patient and the family, okay, that would be somebody in whom I would withdraw as many medications as possible and offer comfort medications and perhaps, all right, offer comfort medications in abundance. Now, we do have one option under hospice care. It's called palliative sedation, right? And that is as the patient approaches the end, okay? Many times they do develop distressing symptoms, shortness of breath, agitation, restlessness, pain, you name it, the whole gamut. In particular, dementing patients, all right, it's restlessness and agitation, in which I may give an augmented amount of medications, including opiates. I may give those medications on a more regular kind of schedule with the idea and the anticipation this probably is going to hasten the dying process. Okay, it's going to hasten it time-wise, but again, to try and provide for as much of a graceful exit as possible.
Yeah, my husband is in DMRC in complete care
Right.
with Alzheimer's.
Right.
And
I'm sorry for you.
I am between saying cut the medications he takes for
The memory.
the memory
Yeah.
and not cutting them.
Yeah.
And I've had doctors tell me, don't cut them because then he will not be able to even do what he does. He can still feed himself.
Yeah.
And then I've had doctors say, you know, he doesn't, I just wish I knew what he can really do.
First, the literature suggests that withdrawing those medications does not make any difference in terms of the trajectory with which things go downhill, okay?
Yeah.
But I mentioned, for example, de-escalating medications. The bargain I would go through many times with patients and their families would be, let's cut back on one or more of these medications and see how things go.
And he gets very agitated.
Okay, yeah, okay, all right, and see how things go, all right? And if things seem to be worse, we can always restart, okay?
Yeah.
All right, but if they don't change, right, it's one less medication that you have to take.
Yeah, well, they have tried that and he does get worse.
Yeah, well, and in that circumstance, if it gets worse, whether or not it's a real physical need for the medication, or it's more of a psychological need for the medication, or a combination of the two, then heck, I would continue the medicines. Okay, yeah.
Yeah, okay.
Yeah.
But that's my question. I just.
No, it's a horrible dilemma to have to deal with, because dementia of all diseases probably has the slowest trajectory from the
Yes.
time of the diagnosis to the time of the death itself, all right? But again, you know, what is his definition of quality?
Well, his definition would be, give me a shot and get me out of here.
Okay.
That would have been what he would say.
Well, and then again, I would even go so far as to discuss with the treating physicians, would you consider the option of palliative sedation at some point in time? And this is very different from euthanasia. I know euthanasia is what's talked about. Euthanasia is when you intentionally give so much of medication that it predictably going to cause death, all right? Palliative sedation is giving enough medication to take the edge off of the symptoms. Yes, it may hasten the time to death, but that's not the intention of the medications. Okay?
I'm glad you could give me that.
Okay.
Yes.
Yes, ma'am.
My uncle, I just wanted to, my uncle is 94 and he is pretty completely demented, but years ago, he wrote a letter to all of us, he's a bachelor, all of us, his nieces and nephews. Setting out exactly, I don't want you to do this, I don't want you to do that. If I can't do these things, I want you not to get in my way. And if you were to have something around like that, or if you had any kind of
Yeah,
anything where he said what he wanted. My mother, we made a video, she didn't have dementia, but she didn't want to be interfered with, and we made a video in case somebody wanted to know, even though we had powers of attorney.
okay.
You know, I agree with your point, you know, unfortunate thing is procrastination.
Yeah.
People just don't pre-plan. We'll spend more time reading the manual how to drive a car than we'll prepare a manual on how to drive
Well,
a
because
life.
nobody's gonna die, did you not find that out?
I didn't get the memo.
Well, the other things are in order.
Now, speaking of that, right, you could have, in addition to your will, with a specific statement or statements in there that say, I get pneumonia, this is what I want done. I want done, I want done. If I become demented, this is what I want done or not done. I've got almost a page and a half addition to my will that states that. You could also put this in online, okay, through the Virginia Department of Health, right? And that should be accessible from any hospital or treatment facility that you go into. You can scan it into your phone, right? There are lots of things you can do so that you have some written documentation. This written documentation carries more
Yeah,
weight, still at the same
What
time.
he wrote was, I consider this your moral obligation. And he was exactly right.
Yes, I wish my husband had written it down.
Right, but it might be someplace he has.
Yeah, you're right. I
But
should look through it.
even then, if you don't have a written document, my fallback position was, what did the patient say when he or she was competent? And what were their directions? And if I had a firm set of guidelines, I'm gonna follow that. I'm gonna follow
Yeah.
it, even without a written backup.
The thing that is difficult is that he still seems to be himself sometimes.
Yeah.
Right?
Typical.
And so it's
Typical.
just really hard to.
Yes.
That's a hard place to be in, really hard.
Yes.
Want to comment that you can contact any hospital patient services.
Yeah.
They will give you information on how you can have your legal documents or your wishes registered through the state of Virginia, and any hospital in the United States can access it.
Yes.
Highly recommended.
Yes. Most hospitals in most states now, if you are admitted, you are obligated to respond to what's called a POLST form, Physician's Orders for Life-Sustaining Treatment. It's sort of a do not resuscitate kind of thing, and it covers relatively narrow field of potential interventions, but at least it's a starting point. And doubtless those things were probably used, tens of thousands, if not hundreds of thousands of times during the worst of the COVID epidemic, right? To help people make the decisions, as hard decisions that it looks like 82-year-old grandma has been on the ventilator for 3 weeks and she's not getting any better. And is it time to consider lessening interventions?
Can I follow up just on
Yes, ma'am.
question?
My advice is better.
Yeah, not yet, so we're good. Would you recommend, this woman consider hospice care for her husband at this point? I'm sorry. Palliative, I bet palliative.
Yeah,
Okay.
definitely palliative, definitely palliative care. Okay, yeah, definitely palliative care.
And is there a time, if dementia patients are not unhealthy otherwise? Is there, he eats like that? We're talking about maybe they can go into hospice, but that is accompanying some other medical problems.
Typically, at least it will be degenerative neurologic diseases, Parkinson's, dementia, in particular, when they have lost self-sufficiency to do the typical activities of daily living, bathing, grooming, eating. All right, then I think palliative care and/or hospice is appropriate. And that really goes for virtually all diseases we deal with. You can't take care of yourself anymore. The end is coming, okay? All right, and again, it raises that quality versus quantity question.
Yeah, okay.
Excellent questions. Excellent questions. Thank you.
Thank you.
Thank you, Dr. Ralph.
You're welcome. Appreciate it. And what's your background?
I spent 20 years in employee benefit insurance corporate, so, well, the interesting thing in 82, same time, we began to